Welcome to all of you joining us from around the world today in this 6th bilingual COVID town hall on the novel coronavirus for the community. The 5 previous ones have been recorded and you can find them on the website. The URL is ahi.ucsf.edu and that will be posted for you at the end of this town hall also. 大家好，午安，歡迎大家嚟參加我哋呢個雙語嘅新冠肺炎第6個城市論壇。咁之前嗰5個咧係嘅論壇咧係錄影咗嘅，咁我哋咧係放咗上 YouTube， 咁亦都係喺我哋嘅網站嗰度揾到嘅。個網站嘅地址咧就係 ahi.ucsf.edu， 咁我哋咧就遲啲喺呢個論壇嘅尾聲嗰度咧係會再重登一次俾大家睇到嘅。咁我今日咧就係呢個論壇嘅主持啦，咁咧就我嘅名咧就係 Diana， 係劉雪艷，係呢個加州大學亞裔健康研究中心嘅主任。咁咧就今晚我係以粵語同埋英語講啦。Now let's introduce our 2 distinguished panelists here today, Dr. Peter Chin Hong and Dr. Laurence Huang, both from UCSF. Dr. Peter Chin Hong has been with our every town hall ever since the beginning. He is a professor of the Infectious Disease Department at UCSF, as well as the Associate Dean for the UC regional campuses. Dr. Chin Hong is also the director of the Immunocompromised Host Infectious Disease Program at UCSF. He has received several distinguished teaching awards and is also like our UCSF spokesperson for the media. He has been invited by both the Chinese news media as well as the mainstream media to do many interviews regarding the coronavirus pandemic. We have captured many of the media clips and put them on the AHI website also. You can go there and hear his words regarding the pandemic. Dr. Laurence Huang is a professor of pulmonary and critical care medicine at UCSF and works in the Zuckerberg San Francisco General Hospital, where he treats many COVID-19 patients. Professor Huang also treats HIV-infected patients with pulmonary disease in outpatient, inpatient, and critical care settings. He also is an avid researcher and has published over 180 peer-reviewed scientific papers. 咁首先咧，又讓我介紹一下呢兩位專家。而家同埋我哋喺呢度呢個城市論壇嘅咧，就有陳子平教授同埋黃斯倫教授。Dr. Peter Chin Hong 陳子平教授咧係 UCSF 傳染病系嘅教授，亦都係 UC 地區校園嘅副院長。陳醫生咧就係喺 UCSF 免疫功能低下嘅宿主傳染病計劃嘅主任，佢獲得咗好多個傑出嘅教學獎，亦都係喺我哋 UCSF 裏邊咧，好似一個代表 UCSF 同傳媒溝通嘅醫生嚟嘅。咁咧就接受咗好多中文啊或者係主流媒體嘅訪問啦，大多數咧就係關於今次嘅冠狀肺炎嘅新冠肺炎嘅疫情嘅。咁我哋咧就將佢嗰啲訪問啊同埋報紙啊咁咧就登咗喺我哋嗰個 AHI 嗰個網址嗰度嘅。咁各位得閒咧係可以上去睇下佢講嗰啲好精彩嘅片段。So anyway, welcome to both of you. And we have a lot of things to talk about today because a lot of things happened in the last 2 weeks. And we were just chatting and it seems like daily there are new things happening with the COVID and we can hardly catch up with everything that's going on. And it seems like what we said before, we are pushing it around and said that, no, that's not it now. Now it's this way or that way. And it's just, this is an interesting virus that just keeps us on our toes. We just don't know what is what for a long time. And hopefully we are getting smarter and we are able to help our patients better with time, more time that has been passing. 咁我哋咧就呢個論壇咧就做咗幾次啦，咁但係每一次咧都係有好多新嘢嘅。咁以前講過嘅嘢咧，成日咧就又推翻啊，一時又話係，一時又話唔係啊咁樣。咁我哋咧就其實每一次做呢個論壇咧都係非常之好緊張，因為即係要成日要 keep up 住咯，因為 嘅都好似有新嘅發生嘅咁嘅。咁我哋而家咧今日咧就好高興呢兩位專家嚟到同我哋又再一齊傾下偈嚇。As in the previous town halls, the agenda has the same format of 3 parts: introduction, the panel discussion, and then we answer your questions at the end. Thanks to those who sent in questions before the town hall. You can send us more questions by typing in the boxes at the bottom of the Zoom screen. If we don't get to answer them here, we'll do it in the next town hall. 咁今晚嘅論壇咧就係包括咗3個部分嘅簡介啦、小組討論啦，同埋係回答你嘅問題。如果你有問題咧，係可以喺同個屏幕嗰個底部嗰度咧有個白色嘅長方盒，你係可以打你嘅問題入去嘅，咁然後就寄俾我哋，我哋係會盡我哋所能去答你嘅問題嘅。So today with the discussion, we are going to concentrate on a specific part that we have not talked before, which is what happens to the patient in the hospital, especially in an intensive care unit. How sick do they get? And why do we need to know about it? So, and Dr. Huang is going to tell us all about it a little later. My role in this town hall is actually a little different than the traditional moderator role, especially in this update session. In addition to moderating, I will also introduce and describe the slides along with the other 2 panelists. 呢個論壇嘅角色咧，係同呢個傳統主持人嘅角色咧係有一啲唔同嘅，因為尤其是喺呢一節嗰度咧，我係會同2位教授咧一齊咧係介紹同埋描述呢啲幻燈片嘅。So let's start with the update on the COVID-19. 咁我哋嘅首先咧就去跟進下呢個新冠肺炎嘅疫情啦。This is a slide of the world of the cases of what we have on the coronavirus as of yesterday.
As you can see on the slide, as of yesterday, there are well over 11 million confirmed cases throughout the world. Cases have been reported in all continents of the world except for Antarctica. And then I think as we're all well aware, unfortunately, the United States is number 1, both in confirmed cases and in confirmed deaths. And I think pretty much everybody agrees that these numbers are likely a dramatic undercount of the actual number of cases and the actual number of deaths due to COVID.
Okay, so let me just quickly say that. 咁其實咧，正話嗰個 slide 就係 show 到全個世界總共有幾多個病例啦，就有成12萬1200萬啊個 case。咁即係其實係好多咯。咁我哋而家咧就知道啦。因為有咁多病例咧，其實佢亦都唔係話專注喺某一個國家，而家差唔多全世界都有噶啦，除咗係南極之外啊，就周圍都有噶。咁本來澳洲嗰度都好少嘅，但係而家都澳洲都喺度我哋爆發緊。This gave the listing. This table is a listing of the 12 countries that are kind of at the top with the COVID infections. So the first column gave the total number of cases, and then the second column is the cases adjusted to 1 million of the population, because each country, you know, some people have more people living in it and some have less. So to adjust to the number of population is a good way to look at which country fares up more. And the 2 triangles shows that when you adjust to the population in the country, actually, the countries that has the most number of cases is not the United States, it's Chile per capita. So, and then United States becomes number 2. The same thing with the total number of deaths. So although US topped at over 130,000 deaths, if you look at the deaths per capita, then it's Spain and UK. United Kingdom topped it, and then Spain followed. And so the numbers kind of shifted when you look at the numbers per capita. And this is median per million people, not just one person, right? So things are a little different. And down there on the bottom is the world total. We've kind of taken a look at that in the slide just now. But basically, we are seeing a lot of new cases every day in the world, which is not good.
I would just add that there's a lot of regional variation in big countries. So that in the United States, the New York area was hit particularly hard and they had a large number of deaths. If you look at the death rate per capita, it's going to be different from the average of the United States.
That's true. 咁呢個咧就係一個表咧，就係 show 到全世界嗰度12個國家最多人感染咗呢個病情嘅國家。但係我哋睇呢個病情嘅時候咧，就除咗睇佢有幾多個 case 之外咧，我哋仲要睇下佢個國家有幾多人口啊嘛，係咪？咁我哋話美國又係最多人死嘅，亦都係最多 case 嘅。咁我哋睇下佢人口嘅時候咧，我哋發覺咧原來咧喺美國嚟講咧，佢感染率啊係第2嘅，係智利咧反為一個本來唔係好多人嘅國家，但係佢如果一除佢嘅人口嘅時候咧，佢係最多人嘅。咁然後咧死亡率嗰度咧就反為咧就係英國同埋西班牙咧就係最高嘅，即係個死亡率。如果係以每個國家嘅人口嚟講。This is what CNN is talking about, that we are really in a bad shape, right? Obviously, we are not in control, and the world knows that we are not in control, and we are in such a bad shape that other countries are shutting us off, that Americans cannot go and land on their country because we are coming from a place where there's so many infections. So if you look at this, all the red places, right, all across the Sunbelt, the hardest hit areas are really Arizona and Florida and South Carolina. And these 3 states alone topped any other countries in the world in terms of the new number of cases per day. Each one of them is more than any one of the other countries. So we are not doing well at all in certain states. And actually all across the Sunbelt, you just count from there: California, Nevada, Utah, Arizona, Texas, Oklahoma, Louisiana, Mississippi, Alabama, Georgia, South Carolina, Tennessee, and Florida. All of these states has a lot of new cases just surging in the last 2 weeks and driving up the cases in the whole United States. So 呢個就係成個美國嘅圖咧，就發覺咧喺南部啊，成個打橫咁樣去嗰個南部咧，係有好多個州咧，尤其是係Arizona 啦、Florida 啦，同埋呢個 South Carolina 呢3個州咧，係每日有好多新嘅案例係發現咗嘅。咁所以咧，呢啲州咧係其實喺度爆發緊一啲疫情。我哋係即係大概應該知道係咩原因啦，因為由嗰個美國亡國日啦，跟住又July 4th 啦，咁係好多嘅原因咧，係好多人係嗰啲州開始開放啦，咁嗰啲人咧一開放咧，佢哋又唔即係自己唔戴口罩啊，就咁周圍咁走咧，咁其實咧就係好多人出去就感染咗嘅。So a lot of it has Dr. Peter Junhong, this 2 weeks of sudden rises in this southern belt, the Sun Belt. What do you think is happening that's causing that?
Yeah, so of course, people have focused on the surges since Memorial Day, and it's continued to increase. So there are things that people can see as a cause, which is people got tired, mass shelter-in-place fatigue. People were being more courageous. They were not afraid of COVID anymore, and they were going outdoors. So people saw those images of people in the beaches, on the bars. But I think what was more invisible was what was going on the inside, driving some of the increases. So a lot of graduation parties in California were driving some of the outbreaks. Some of the work parties, and also in some of the southern states like Texas and Oklahoma and Mississippi were fraternity parties and pledge parties. So there were a lot of things happening on the inside, as well as the things that people saw in the news. But I think the inside outbreaks were less visible to the public.
And also the meat plants, right?
The meat packing, those were part of like around Memorial Day and continued. But then people started going out, and there's a lot of, in different states, there are different reasons, but essentially mass, shelter-in-place fatigue, mixed messaging from the public health early on, but not wearing masks. So people were confused. A lot of distance between science and public health, what they were saying and what the public wanted to do. Like in California, for example, where there were threats against public health when they wanted to institute masking. So a lot of different reasons, but that's why we are. But mainly, if you want to talk about a big reason, is that we didn't have one unified voice and one unified approach from the country to the virus.
咁Dr. Peter Chin Hong 咧就陳醫生咧就話，主要嚟講咧，我哋係即係美國啊，係冇一個好正確嘅姿態去對待呢個病毒，係話係咁樣你做就啱啦咁。因為有啲人咧又話呢樣，有啲人話嗰樣，咁其實咧嗰個社區咧就其實好混亂嘅，就以戴口罩嚟講啦，我哋初係叫人話唔使戴口罩㗎，咁即係不同嘅原因話叫你唔使戴嘅咁。咁但係而家咧又話要戴啦，但係而家唔止話要戴，係一定要戴，係非常之嚴重嘅一個問題嚟嘅。點解咧？就係因為而家我哋又話，以前又話嗰啲空氣唔會傳染，而家又話空氣會傳染。咁所以咧就即係好多原因係整到美國嘅情況係咁差咯，非常之混亂嘅情況。So this slide we have shown before, but we are showing it again just to show where we were and where we are now, right? So today, as of today, we have 3 million cases in the U.S. But just back in March, even though in the beginning of March, we are only having 100 cases. Well, at the end of March, then we got up to 100,000, which is 1,000-fold. But now, March, April, May, June, right? April, May, June. And in 3 months' time, we went from 100,000 to 3 million. That is so astounding. That's 30 times in 3 months. And so that's what we are looking at. So 呢個就係我哋以前已經俾過你哋睇嘅，講翻出嚟咧就只係睇翻，即係以前咧，即係3月頭嘅時候先100個 case 啫嘛，到3月尾都係10萬個 case。你話3月頭到3月尾已經起咗1000倍啦，但係而家由3月尾1000個 case， 1萬個 case， 10萬個 case， 到而家7月頭，而家已經係3 million， 係300萬個 case。由10萬到300萬，又加咗30倍。咁呢個我哋係非常之即係好詫異咯，係起得咁快。但係呢個主要嚟講係因為我哋係控制得唔好嘅而家疫情。So any more to add about this quick increase of the cases, the two docs?
I could start off and I would see if Laurence has anything to add, but I think a lot of it initially was, well, first of all, we were vastly underpowered to do testing for a variety of reasons where the US had missteps. So a lot of the early cases were very completely off the mark of what was going on in the community. And then we started to do more testing. So that ramped up the cases very quickly. And now we have a combination of more testing. So you're going to find out more people in the community, but also actually more cases because you're finding people who may not have symptoms, who may be asymptomatic, etc. So, you know, it's a complex situation, but it is a true case increase. And this is an underestimate of probably the amount of cases we have in the community because we still don't have enough testing. There's still people who can't get tests when they want it. You have to have a symptom in many places. And that's been all over the media as well. And even at UCSF, you can't get, unless you're coming into the hospital for surgery, if you're in the community at UCSF, you need to have a symptom as an employee before you get tested.
And that totally negated what we were telling the community about these asymptomatic COVID-infected people capable of infecting others. We just let them go, really, right? Because if we don't care if you're asymptomatic, we don't test you, go and infect others. Is that the message that we want to give to people?
I think in the beginning, asymptomatic transmission wasn't really well appreciated. As the data started coming out, even at UCSF, I remember when I was talking about it, somebody actually yelled at me because they said I was making people fearful and anxious. And they were like worried that they would get COVID in the community. But of course, it ended up being a thing. And, you know, unfortunately, unlike SARS, people spread infection before they feel symptoms. So that's why this is even more likely to spread in the community, is because people don't know they have it.
Right. That's almost like people wearing masks. If you wear masks on the outside in the early days, people laugh at you. Or some people would just tell you to butt off or something, you know, because you're wearing masks. They're not too nice about people wearing masks.
No, and it's stupid to have a debate about who should wear the mask. People are quarreling on social media about should you put a mask on the person who has infection and the person who doesn't have it doesn't have to wear a mask. But the point is you don't know who has infection and who doesn't. So it's really not a good argument to make.
Well, now that we know how things has changed in the last few weeks, right? So now, today there was an email that came out from UCSF that tells us that wearing masks is so very important, right? Everybody should wear a mask, whereas before it wasn't the case. Dr. Huang, what have you seen over at San Francisco General about this mask wearing? It's so important. We want to spend a lot of time talking about it.
Similar to what Peter said, I think at the beginning of the epidemic, before we had a good appreciation for asymptomatic and pre-symptomatic spread, the staff at the hospital were not wearing cloth masks, where now, as in UCSF, it's mandatory. You can't come into the building either as an employee or as a patient or a visitor without wearing a mask, but that was not the case for the first several weeks or maybe 2 months of the pandemic. So I think as our appreciation of the disease and how it's transmitted has improved, so have the measures that the hospital has taken to address those issues.
Daniel, do you want to translate that? Because I have a really good question that I wanted to ask Dr. Huang for a long time, actually.
So, 我哋即係不嬲就係戴口罩咧，係一個好大嘅問題嚟嘅。初初戴口罩嘅時候，我哋係俾人笑噶嘛，係唔需要噶嘛。但係而家咧，我哋發覺咧，所有嘅態度都改變咗，係而家咧個個人都係話叫你一定出外要戴口罩，咁所以個態度已經係轉咗。咁啊，希望各位網民咧都係有戴呢個口罩嘅習慣咯。因為喺出邊咧都有人，仲仍然係有人係唔戴口罩，亦都係有人鬧你嘅。如果你戴口罩，但係你要自己企硬個宗旨，就係戴口罩，佢會幫到，唔止係幫到我哋自己，係幫到人，唔會感染人。呢個係非常之重要。So what was the question that you want to ask?
So, Dr. Huang, there are a lot of naysayers about masks, which are not very common in the Asian community, but if people are in social media and in the community are saying, you know, if I could, you know, they use these OSHA probes to show that you can have too much carbon dioxide behind the mask. And if you have lung disease, you might suffocate because you wouldn't have enough oxygen to breathe. How would you respond to those critics as a pulmonary doc and using masks forever in patients who have pulmonary disease?
So I think you already know the answer to this question, but wearing a mask, even the most restrictive N95 mask, which physicians wear in the presence of positive cases or in the presence of any aerosol generating procedures, will not decrease your oxygen level and will not raise your carbon dioxide level to any significant extent. And you cannot use those arguments to argue against wearing a mask. Period.
呢個真係一個好好嘅 question 啦，因為好多人咧唔肯戴口罩咧，就話我戴住口罩焗住我，咁我咪吸少咗好多氧氣咯，而且我焗住我噴咗出嚟嗰啲二氧化碳，我又吸翻入去，咁我咪變咗係吸咗，即係個肺裏邊多咗啲二氧化碳，少咗呢啲氧氣咯咁。咁啊，黃醫生咧係一個肺科嘅專科醫生嚟嘅，咁佢話咧其實你如果戴口罩，就算係戴一啲好密嘅口罩，即係好似 N95 啲咁嘅口罩咧，都唔會減低你吸入去個身體裏邊嗰啲氧氣，同埋會吸多咗啲二氧化碳。And why is it not? Because you actually are breathing in the air that you breathe out because it's sitting in the mask. Why would it not increase the carbon dioxide and decrease the oxygen, Dr. Huang?
Because those gases are going to diffuse through the fabric, right? They're not, you're not wearing something that's impermeable to gas. So there's no question that oxygen can go through the mask. There's no question that carbon dioxide can go through the mask. And so that's why I said wearing even a very restrictive N95 mask is not going to block the oxygen nor the carbon dioxide from going through the mask. And obviously, if that's the case with the N95, it's even more so the case with surgical mask, which many people are wearing, and obviously with a cloth mask.
你睇到 Dr. 陳醫生喺度猛咁點頭 ，Dr. Chin Huang spitting, nodding his head the whole time as Dr. Huang's talking.
No, but it means a lot for a lung specialist to say that. Really, it carries a lot of weight.
Yes. 因為黃醫生咧係一個肺病嘅專科醫生咧，所以我哋係唔可以同佢拗嘅，因為佢對個肺裏邊嗰啲嘢，佢係知道得非常之清楚，比我哋任何人都知道清楚嘅。咁黃醫生咧就係話，因為嗰啲任何嘅口罩啊，佢都係會有透風嘅，所以咧係唔會話完全係 block 住晒嗰啲氧氣又入唔到去啊，啲二氧化碳又出唔到嚟啊，咁所以大家係唔需要擔心呢樣嘢。Okay? So this is a cutout of the Mercury News. Back in, you can see the red circled area, Thursday, May 28th. That's the news on that day. On that day, California has 100,000 cases, so it's a landmark. And then the US has 100,000 deaths. So it was a landmark day for 100,000, both for the state and also for the nation. Okay, so if we were to look at July now, July 8th, we actually today has close to 300,000 cases now. So from 100,000, we come to 300,000 for the state of California only, okay? And then for the US, now from 100 deaths, we have over 500 deaths now. And then we have 3 million cases. So you can see the jump within 2-3 months. It's just horrendous. So again, it just brings us back to history. So Dr. Peter Chin Huang, you want to say something about this slide?
Actually, we wanted to ask the audience. I know we are always running over, but I thought it would be fun to just get one answer from the audience as to what people think of these 5 activities is the riskiest for getting COVID.
So we're
going to put it in the Q&A.
Going to the church, grocery shopping, go to see a doctor, and barbecue in the backyard. So think a second, which one is the riskiest? So let's go to the next slide and take a look at what the Texas Medical Association has come out. These are the scores. And on the list, I know they're small, it listed the activities for you. And so what the Texas Medical Association, as I'm sure that there are other places that have done this, I just happen to know about this, and that is that people assign a risk score to the activities that you do. So as we talk about the new normal, as to now we have the COVID-19 and we don't have the vaccine, and what should we have to do? This may be one of the things that we need to do, which is to think about things before you do it. Think about where you're going before you go. And because every place and everything that we do carries a certain amount of risk of contracting the virus. And so we have a score of 1. The score of 1 is like opening mail at home, like you pick up mail from the mailbox. The mailman has touched it, so there is a little risk, but it's a very low risk, and it has a score of 1. So it basically tells us that it's okay to open mails. And then we have up to 9, and that's going to large gatherings of people. So, and this actually activity levels were kind of like used for by many states in terms of the reopening as to which kind of activity they can reopen first. Of course, they would try to use the ones that has lower risk before they go to the ones with the high risk. And we're seeing that in the state of California, in the 4 levels of opening, we're at stage 2, at the lower level of stage 2 of keeping things like we can get things picked up from the curbside. We can go for essential stuff like buying groceries, but not for non-essential stuff yet. We were going to open to that, but with the surge in the cases, everything comes to a halt and seems like we are kind of rolling back. I hope that all of you have picked your answers for those activities. Here are the scores for these activities. So Dr. Peter Chin-Hong.
So I think the quick and overall summary answer is any place where you can't control your environment is the riskiest. And there are actually, most people who I looked at, they chose going to the bar and going to church, which, is similar. Of course, I probably would say going to the bar is a little bit more risky because it's more uncontrolled and people are shouting and screaming. And going to church could be less risky if it's a small congregation, people are far apart. So it just depends on that environment control. And probably the safest is staying at home, going grocery shopping with a mask on in not a crowded grocery, but because they're limiting people. So that's basically what it is. I would say going to the doctor is somewhat safe. I think the number is probably higher than I would probably rate it right now. And I'd probably put it lower than 4 because in Texas, they probably didn't have universal masking. At UCSF, we have universal masking. So it's going to be much less risky than a 4 and probably less risky than the grocery shopping, to tell you the truth.
And then the one in the backyard barbecuing, that's a number 5.
Yeah, it's 5 because those people are a lot. If you have just barbecue with your family, it's pretty unrisky. But if you have barbecue with 10 dim sum tables, then it's not a good problem.
I think one of the main issue is where you will be wearing masks or you will not be wearing masks. So When you're eating and drinking, you're eating in a barbecue, you're drinking in a bar, your masks are off. Even if you were wearing a mask to go in, that puts you in a higher risk category.
And remember in Hong Kong, a lot of the transmissions were in hot pot when people were taking their masks off.
Yes, eating in restaurants. They now have an outbreak. Hong Kong now has an outbreak in cafes. Many cafes were associated with people who have been there and they got infected now. So the businesses are very worried that they will be asked to shut down. So 呢幅圖咧就係俾你哋睇嗰啲邊樣嘅做邊樣嘅嘢有啲咩嘅風險啊。咁咧主要嚟講咧，你就要睇下係有幾多人啦，即係可唔可以隔離啦，即係隔離6尺啦。如果係坐得埋嘅又近嘅，連口罩都唔戴嘅嗰啲咧風險就非常之高嘅。咁啊，譬如去酒吧啦，去酒吧飲酒冇理由戴個口罩㗎，係咪啊？點飲啫？咁啊喺後一嗰度 barbecue 食嘢啦，食嘢嘅時候又要除口罩啦。咁如果你食嘢嘅時候係同啲外人食嘢咧，同埋自己家人食嘢咧，又唔同嘅風險啦喎。咁所以咧就咁睇醫生咧，嚟你見到呢個醫生幅圖咧，佢係冇戴口罩嘅。但係我哋因為如果戴口罩嘅時候咧，所以個風險咧又低咗好多嘅，因為個個都戴口罩啦，咪見醫生，病人又戴口罩，醫生又戴口罩。咁啊，如果係要買餸嘅，買餸個個都要戴嘅。咁如果你戴咗手套啊，同埋戴埋口罩啊，咁個風險都減低咗嘅。So this is California today as to what stages they were in. Well, it was last week, but this week some of the counties are going to go back. But in the last 2 weeks, the state of California, where the dark green is, they're in advanced stage 2. That means that barber shops are open and you can go and eat in restaurants and schools will be open and you can go to church and, different things. And so, whereas in the lighter green area, that's basically the Bay Area. There's several counties in the Bay Area. And we have been more conservative. And that even though our numbers are relatively in control and much better looking than other places in San Francisco, and so that we still didn't open up to the advanced stage 2. We were only in the early stage 2, which means curbside pickup and the minimal stuff, the essential stuff that we're allowed to do. So this is the way that California is going. So 呢個綠色嗰個咧就係其他好多州即係加州裏邊其他好多縣咧都係開放咗好多噶啦，前嗰2個禮拜。但係而家咧佢開放咗咧，佢可能要閂翻啦，因為有疫情爆發啊嘛。咁咧喺灣區嗰度咧，我哋咧就唔係開放好多嘅啫。咁而家咧都係暫時就留住咁嘅位置咯，就本來想再開放多啲，但係而家暫時因為疫情爆發就唔再開放。
This is the California data. I think Some of this has been in some other slides. I think the one key point that is circled in the middle and the left is that as the epidemic has evolved, it's now currently involving many of the younger generation, as opposed to perhaps in other countries and in the US, where the original wave was predominantly in more elderly individuals.
Right. And on the bottom, you have the hospitalizations. That brings you kind of close to your talk a little later about the ICUs. 呢個就係嗰個疫情嘅年輕化。而家感染嗰啲人係好多人都係50歲樓下嘅。So 以前咧就50歲樓上嗰啲係多感染，而家係50歲樓下嗰啲多感染。
So again, I think similar types of data have been shown. Moving from California to San Francisco, where I believe many of the attendees are from, this was the San Francisco epidemic up until a few days ago. And so there have been a fair number of cases, and I think quite remarkably, only, and I don't want to mean that in a trivial way, but only 50 deaths.
50個人死咗，即係死亡率咧就冇加高嘅。
So as all, I think, cities and counties and states and countries now have, San Francisco has their own COVID database. This slide here is the number of cases currently in San Francisco. And again, you can see sort of where the epidemiology is, where there are many cases in younger individuals. And one of the striking things that we've seen in San Francisco, which is similar to many other areas of the country, is the predominance of the epidemic in the Hispanic or Latin community in San Francisco.
呢個我哋睇到係三藩市嘅個案咧，又係即係年紀咧就係年輕化咯。你睇到係50歲樓下嘅人係大部分嘅人係感染嘅。咁然後黃色嗰度咧，嗰啲就係黃色右手邊嗰個係種族啊，係大部分感染嘅人咧係嗰啲西班牙裔啊，或者係拉丁裔嘅人。
So the prior slide showed cases. This slide shows deaths in San Francisco. And if you look at the age group distribution, you see that unlike cases, which are predominantly in younger individual, deaths predominantly, as you already know, are in older individuals. And then another interesting epidemiologic feature of the epidemic in San Francisco is if you look at the race ethnicity box, whereas in the prior slide for cases being dominant in the Hispanic or Latin community, in San Francisco, the deaths have been predominantly in the Asian community.
At first, we don't know the race and ethnicity of the people who died. And ever since the data came out from day one, Asians has been hovering around 50%, sometimes a little more, sometimes a little less. Now it's around 46%, still very close to 50%. And we still don't know why. And so maybe Dr. Huang can give us some hints a little later. But 呢個就係三藩市嘅個案嚟嘅。又係睇到死亡，呢個係講死亡嘅個案，就大部分死亡嘅人睇年齡咧，中間嗰個咧，上面嗰度中間嗰個咧，就係多數係60歲以上嘅人，最多嘅咧就係80歲以上嘅人死亡嘅。咁然後睇下種族方面咧，反為雖然係拉丁裔係好多人感染，但係咧佢哋死亡唔係咁多嘅喎，但係死亡嘅人數最多咧就係亞裔嚟嘅。And so what we're seeing is that the different color lines represent different age groups. The red line is the top line that's 65-year plus. And of course, the lower lines are the younger age categories. And you can see that in general, the hospitalization by age groups has been going down, which is a good sign. And because there's more going down of the higher age groups, so proportionally, it seems like there is less people hospitalized in the older age groups. It's more equalized now between the different age groups for hospitalization. But this is a encouraging slide to know that less people are getting hospitalized. 即係少啲人係住醫院而家。 So this one is per race, the number of people hospitalized per 100,000 people. And you can see again, when you adjusted it to the population, then we see a different picture. Then the highest number of people getting hospitalized are actually the non-Hispanic American Indian or Alaska Native Indians. And then the non-Hispanic Black is the second highest group, and the Hispanic or Latino group then becomes the middle. They are no longer the highest when it's adjusted to population. And then the whites is the lowest, followed by the Asians. So we see a little different picture when it's adjusted to population. So 呢個就係如果我哋以人口計嘅咧，每10萬人口嚟計係有幾多人感染咧？最多嘅人感染咧係嗰啲印第安人或者係阿拉斯加嗰啲原住民啊。咁然後咧黑人咧就第二嘅，咁啊跟住到西班牙裔或者拉丁裔。So these are the medical conditions associated with people who are hospitalized. And you can see that there are 4 medical conditions that stand out. High blood pressure, obesity, and diabetes and cardiovascular disease. And it surprised me to see chronic lung disease and asthma not being one of the top ones, Dr. Huang.
I don't know that I have a specific explanation for that. Often those individuals are more susceptible to all sorts of respiratory illnesses. So I don't know that I have a great explanation for that observation.
OK， 咁即係而家我哋睇到咧，住醫院嗰啲人咧，好多人咧都有不同嘅長期嘅患病啦。最多人咧就有血壓高，跟住糖尿病啊、肥胖啊，同埋心血管病啊嗰啲咁。咁咧就呢啲係嗰啲喺醫院裏邊住嘅病人嘅情況嘅，佢哋自己嘅身體嘅狀況嚟嘅。So this talks about the capacity of the hospitals that we have now, right? That was a slide that you picked, Dr. Huang.
I don't believe I gave this slide.
Oh, no? Okay. So then we're just talking about, because the capacity of the hospital is one of those determining factors that whether we open up to the businesses more or less, right? Depending on whether we can accommodate the patients if people get sick and have to be hospitalized. So, but basically, in general, what we are seeing is that if you look at the curves on the right-hand side, you can see that the very bottom part where it's a little more dark gray, that's the hospitalization of the COVID patients. The lighter gray area is hospitalization of the regular patients. So because hospitals have opened up, back up, and accept other patients now. And then the green part, basically we can bet that we can take in more patients. So hospital-wise, it's we are doing good, and we've been helping other places. Like we've been having patients transfer from the San Quentin prison, as well as patients transfer from Southern California, right, where the hospitals are getting filled, and we are getting some of their patients from like the Imperial County and some other counties. Have you taken care of those patients in San Francisco General or UCSF? Yeah. From other places?
Yeah, we have both Imperial County and San Quentin here. Actually, 50% of our ICU at Parnassus is from out of county right now for COVID.
Okay. How many patients do we have now at UCSF?
We have about above 20, so about double where we were 2 weeks ago, 25, 25. And we're 75% capacity at ICU when I checked over the weekend.
75 available or filled?
No, 75% full.
Oh, that's pretty full.
Because it's like a mix of COVID and non-COVID, like you said.
Oh, I see. What about San Francisco General? What's the situation?
The situation today is not too bad. We have, I believe, 5 patients in the medical ICU who are either known to be COVID or are high probability persons under investigation. And then I believe we have also taken transfers from Imperial County, and I'm not 100% sure about San Quentin.
I see. So 我哋喺三藩市醫院情況咧係相當 OK 嘅，因為我哋有大醫院喺呢度啦，咁所以咧有啲其他嘅病人咧都嚟我哋醫院嗰度醫嘅，咁就未必係我哋自己三藩市本市嘅病人嚟。咁譬如喺 San Quentin 呢個監獄嗰度啦，咁送咗啲監犯嚟，因為嗰度有個疫情爆發，係好多人感染咗，有成1000幾個人感染咗，咁就送咗啲病人過嚟嘅。咁咧就南加州啦，南加州又爆發啦，咁佢哋咧又送佢哋嗰啲醫院差唔多滿晒床啦，咁所以咧就將呢啲病人咧就送上嚟呢度北加州嘅。咁我哋三藩市嘅總醫院咧，同埋UCSF 自己本身嘅醫院咧，都有容納呢啲咁嘅病人。咁我 Dr. Huang 咧就話喺個週末嘅時候咧，我哋大概係70%半滿啦。咁黃醫生咧就話喺舊金山醫院嗰度咧就只係得5個有呢個病毒嘅病人嘅啫，咁所以都係相當情況 OK 嘅。
I'm going to go a little more quickly through some of the introductory slides because I think most of the attendees are interested in hearing a little bit more about the ICU, which I think is a new topic for this group. So as you know, the severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2 is the cause of the disease that we call COVID-19, which stands for coronavirus disease 2019, which is when the disease was first described. It's related to the original SARS coronavirus, which was on a much smaller scale almost 20 years ago, at the end of 2002, stretching into 2003. And the coronavirus got its name from the Latin word corona, which means crown. And that was because each coronavirus virion is surrounded by what's called a corona or a halo akin to the sun's corona, as you can see on the picture to the right.
咁大家可能都知道呢個冠狀病毒啦，佢嘅叫嘅原因咧就係因為佢個形狀好似個皇冠咁樣樣，係咪？咁呢個冠狀病毒咧，其實初開始嘅時候咧，呢個首先嘅字俾呢個病毒嘅咧，就係2002至2003嗰陣時 SARS 爆發嘅時候。咁所以咧，而家要冠狀病毒咧，根本係有個 SARS 個名喺度嘅，叫做 SARS-CoV-2。OK，2 咧就因為而家呢個係第2個啊嘛，1咧就係 SARS 嗰陣時啦嘛，嗰陣時嗰個1啦。咁而家咧呢個咧個病情咧就叫做新冠肺炎啦，就叫 COVID-19。
This is constantly evolving. Anybody who reads the newspaper or is on the internet knows that this is a evolving topic, but the current understanding is that the vast majority of cases of COVID result from person-to-person transmission. And this is most often thought to occur from close contact with an infected individual. And the route of transmission is believed to be mainly through respiratory droplets. In these particular cases, the virus is released in respiratory secretions that result when a person who has the infection coughs, sneezes, or even talks. And these droplets tend to be bigger particles that do not travel in general very far, typically thought to be less than 1 meter or 2 meters, so less than 6 feet. And that informs the primary current intervention, which is social distancing as well as wearing a mask, both to protect you from giving coronavirus to other individuals, and then maybe secondarily to make it a little bit harder for the big particles to get through the mask and into your mucous membranes. There's an evolving controversy, although as a respiratory specialist, I don't think it should be a controversy, about whether there's also aerosol or airborne transmission. These are smaller particles that can travel longer distances and can remain in the air for longer periods of time. I think people who've read the newspapers know that the WHO had not really come out suggesting that that was a mode of transmission or a frequent mode of transmission. But I think the medical societies and medical professionals have pushed back against that And as a respiratory specialist, I'm pretty sure there's airborne transmission of coronavirus. You can find the coronavirus in other non-respiratory specimens. So it's found in stool specimens as an example, and that raises the possibility of other non-respiratory routes of transmission. And then there's also what's called transmission from fomites, so infected surfaces, that I think in particular circumstances can be a mode of transmission, but those are probably not the dominant modes, the last two. The thought is that the primary mode is respiratory droplets, person-to-person transmission. As you're also aware, it's not just the symptomatic people who are actively sick and are coughing and sneezing who can transmit the infection, but people who are pre-symptomatic, so they don't have symptoms yet, but they're going to develop symptoms shortly. And then people who are asymptomatic and never develop symptoms can also transmit the infection.
咁而家講一講呢個新冠病毒嘅傳染，主要傳染嘅途徑呢，黃醫生呢就係話由人傳俾人嘅，咁就係大家企得好埋，咁呢個近距離嘅接觸之下呢，就係由個口嗰度唔覺意噴出嚟嘅口水嘅飛沫呢，而傳染到俾其他身邊嘅人嘅。咁仲有其他嘅傳播途徑嘅喎，就係譬如喺空氣中啦，啲病毒亦都係可以吸咗入去嘅，或者咧甚至喺糞便方面，咁口水啊咁，亦都可以傳染嘅。或者咧嗰啲口水當佢跌咗落去啲台面啊、地面啊嗰度咧，咁我哋如果摸咗佢，而唔覺意又摸下眼啊、摸下鼻咁咧，就由我哋隻手咧就帶咗啲病毒咧入咗我哋嘅呼吸系統傳染啦。咁呢啲咁嘅傳染嘅途徑咧，就直接影響到我哋做防禦嘅方法啦。因為如果佢係喺空氣啊或者口水方面可以噴出嚟傳染嘅咧，咁我哋戴口罩又有用啦，大家分開企遠啲又有用啦，即係唔好企得人哋咁近咯。咁常洗手啦，因為隻手可能係摸到啲污糟嘅嘢，咁而帶入我哋嘅口鼻啊嘛，咁我哋咪話常洗手，用番梘洗手就可以將啲病毒殺死，唔使傳染落我哋自己嗰度咯。同埋咧叫我哋大家好成日摸口摸面啦，咁戴住個口罩咧，亦都有防衞我哋自己唔覺意碰到個鼻啊，或者係碰到個口啊咁樣嘅情況嘅。咁我哋要知道咧，呢啲傳染嘅俾我哋嘅人咧，佢哋可能有象徵啦，但亦都係可能冇象徵嘅喎。咁大部分嘅人都係有象徵嘅人，即係有呢個症狀嘅人啊，嚟傳染俾我哋啦。但係如果係冇症狀嘅人咧，佢哋可能係喺啱佢自己都啱感染咗嘅，咁頭嗰一兩日咧佢自己都冇症狀嘅，但係佢已經有病毒噶啦。咁或者咧有一啲人咧係感染得比較輕微啲咧，佢自己係完全全程係冇症狀嘅。咁呢啲人咧雖然佢哋冇症狀，但係佢哋亦都係可以有能力傳染呢個病毒俾我哋嘅。
So there's an ever enlarging list of symptoms that are associated with COVID. For the purposes of our discussion, the primary symptoms to worry about are fevers or chills, cough, shortness of breath, or difficulty breathing. But other symptoms include fatigue, muscle or body aches, headache, loss of taste or smell, sore throat, congestion or runny nose, nausea, vomiting, or diarrhea.
咁大家見到呢啲圖咧，就係呢個有新冠肺炎嘅病人，佢可能有嘅症狀。咁咧，大家就最常見嘅咧就係發燒啊、乾咳啊，或者係發冷啦、肌肉痛啦、呼吸緊促啦，呢個係非常之嚴重嘅。咁或者係有頭痛啊、失去味覺、嗅覺啊、喉嚨痛啊、嗰個鼻又流鼻水啦，甚至有作嘔啊，或者真係嘔咗出嚟嘅情形，同埋或者會肚屙嘅。咁大家要留意嘅咧，就係呢啲症狀咧，我哋係唔可以列晒出嚟嘅，因為有啲症狀咧唔係咁顯著嘅，尤其是喺老人家嗰方面啊，有啲症狀係比較模糊啲嘅。咁所以咧最好咧就係大家如果有症狀嘅時候，當你唔係好確定嘅時候咧，就唔好猶豫，唔好嘥時間，打個電話俾個醫生去做個檢測，就睇下你自己係咪有染呢個新冠病毒。如果有嘅時候就可以早啲醫治咯，可能咁咧，因為我哋喺亞裔之中咧，係好多人入院嘅時候，我哋發覺佢哋嘅病情已經係好重啊，所以我哋喺三藩市亦都睇到咧，呢個亞裔嘅死亡嘅人數咧係佔咗 全部死亡人數嘅差唔多一半嘅，咁所以大家都要喺呢方面留意下，就盡快去同個醫生聯絡。
And Dr. Huang, from some of the patients, from what I know, this pain is not a simple pain. It's really very, very painful. And the fatigue is like, it's not a little fatigue. It's so exhaustive, they couldn't even do very much. It's that kind of a fatigue. You see that in the ICU patients?
I believe that's probably going to be the case. Unfortunately, by the time most of the patients end up in the ICU, as I'll talk about in a little bit, they don't have the ability to talk to us. They're on a mechanical ventilator, and so we can actually get a direct history from them. So if you have any of the symptoms on the prior slide, and they're lasting more than a few hours, I think the general recommendation should be you should err on the side of caution, and you should contact your primary care provider by telephone, but probably not necessarily go to the emergency room. This slide here indicates when you should go to the emergency room. So if you have trouble breathing, persistent chest pain or chest pressure, new onset of mental confusion, if you're unable to stay awake, or if you notice that your lips or face are becoming blue or what we call cyanotic, you should call 911. You shouldn't wait at home. In addition, people who are older, so 65 or older, and people with underlying medical conditions such as heart or lung disease or diabetes, you should have a lower threshold for presenting for medical attention because you're at higher risk for severe complications, including death.
呢個係一個非常之重要嘅環節嚟嘅，因為咧，當有病嘅時候咧，有一啲病人咧係唔需要入醫院嘅，有一啲病人需要入醫院嘅。咁到底幾時你先至決定係要唔要入醫院咧？即係醫生會同你幫你做決定，但係你都要識打個電話俾個醫生先得㗎。咁第一就係你唔好自己叫救傷車入醫院，你應該打咗電話先，問咗醫生先，等佢哋叫個即係急救室嗰度啊，要預備啲嘢嚟到迎接你嘅。咁到底咩情形咧？就譬如你唞唔到氣啦，個心口痛啦，持續咁樣痛啦，個神志有啲混亂啦，又即係講嘢又可能唔係幾清，即係口齒不清咁樣啦，或者咧你個口唇咧或者個面咧變青晒嘅，藍青青嘅，咁即係唔夠氧氣啦，知嘛？咁所以咧就要去醫院啦。咁尤其是老人家啦，如果你係有心臟病啊、糖尿病啊、血管病啊，咁你自己知道有啲長期病嘅咧，呢啲咁嘅病咧係會增加你嘅風險，就唔好揾自己救飛啦，就要打電話俾醫生，然後就跟住去醫院。Next slide, please.
So in the interest of time, I'm going to mostly skip through this slide, other than it's similar to some of the earlier slides that we showed, where you can see the profound influence of age on hospitalizations. And this is US country data, not San Francisco County data.
而家呢張圖咧，就係喺醫院裏邊患咗新冠肺炎要住醫院嘅病人。咁我哋見到咧，主要嘅病人咧，佢哋嘅年齡啊，都係比較高啲嘅。咁咧，你見到綠色最長嗰條柱咧，就係85歲以上嘅。咁跟住咧就係65至75歲啊，75至85歲咁所以咧大部分嘅病人咧都係年事高嘅病人嚟嘅。
Again, this is US data from the CDC. It's a little bit from earlier parts of the epidemic, but the 2 points or 3 points that I want to make from this slide are that of the, at that time, 1.3 million laboratory confirmed cases of COVID, 14% of the cases, the patients had to be hospitalized. And then of the same 1.3 million cases, 2% required ICU admission, and then 5% died. And so the point of this slide is to suggest that most patients with COVID do not need to be hospitalized, and that most patients who are hospitalized do not need the ICU, but there is a very small percentage of very significant cases that do require ICU care.
咁到底有幾多患咗新冠肺炎嘅病人要住醫院呢？嗱，呢個咧就係5月尾嘅數據嚟嘅，當時咧就大概有132萬人咧就有呢個確診啦。咁喺呢個百幾萬嘅人數之中咧，就係有10幾萬嘅人咧就係要住醫院嘅，大概係1成4度。 咁咧要住深切治療部嘅咧就少好多啦，就只係得2%。咁然後咧就其中咧就係有5% 嘅人死亡嘅。咁即係話喺全部嘅確診嘅病症之中咧，就大概有半成嘅人係死亡，大概係2% 嘅人係要住深切治療部，所以嗰啲 number 咧其實都係相當細嘅。
Dr. Huang, you just made our president a liar because he said on television that 99% of the patients are okay. And this is not what it says here.
In the interest of time, I'm going to save that maybe for questions later.
I would definitely trust Dr. Huang. I always have, ever since I came to UCSF, and I will continue to.
So these are some of the major complications of COVID. I highlight the 3 that involve the lungs because I'm a lung specialist, but pneumonia, which is infection of the lungs, is probably the most frequent complication. Severe cases of pneumonia can result in the acute respiratory distress syndrome, or ARDS, and that usually requires ICU level care. But patients with COVID-19 are also developing blood clots, both in their leg, and the clots also travel to their lungs, and they develop what's called pulmonary embolism.
咁呢個新冠肺炎啊，到底喺我哋身體上會產生乜嘢嘅主要併發症咧？咁黃醫生咧，因為佢係肺專科醫生啦，咁佢咧就想同大家講一講喺肺裏邊主要嘅併發症就有3個。第一個咧就係肺炎，即係咧喺呢個病毒嘅感染之上咧，再加多一個細菌嘅感染。第二個咧就係我哋所謂講嘅簡稱叫做 ARDS 啦，就係呢個急性嘅呼吸困迫綜合症，呼吸困迫即係氣喘啦嘅綜合症。咁咧呢個咧就係由於個肺裏邊咧有好多氣泡仔噶嘛，咁嗰啲氣泡仔咧佢個膜咧就爛咗，咁咧嗰啲血水咧就流咗出嚟，咁咧就積咗喺個肺嗰度啦，咁啊變咗肺積血水啦，係嘛？咁咧呢啲血水咧就整到個人咧呼吸得唔暢順啦，就好多時整到佢氣喘啦。第3個咧就係由呢啲血塊而形成嘅，就叫做血栓塞併發症。咁簡單嚟講係咩咧？就係話呢啲血塊喺個血液裏邊產生咗血塊，呢啲血塊咧就周圍走啦，去到個肺嗰度咧就叫做肺栓塞。咁呢個咧係可以致命嘅 ，OK？ 咁去到個腦嗰度咧就變咗係急性中風，亦都係可以致命嘅。咁所以咧呢個新冠肺炎咧係帶到一啲好嚴重嘅併發症俾我哋嘅。
So as I mentioned already, pneumonia is the most frequent serious manifestation of COVID. The typical symptoms of pneumonia include fever, cough, and dyspnea or shortness of breath. You can see the percentages of COVID patients who presented with each of those symptoms.
咁正話黃教授都講啦，喺呢個新冠肺炎裏邊咧，最重要嘅併發症咧就係肺炎再加肺炎，即係一個病毒嘅肺炎，再加上一個細菌感染嘅肺炎。咁到底呢啲肺炎有咩象徵咧？咁我哋咧知道肺炎咧其實有3個主要最大嘅象徵，第一就係發燒啦，第二咧就係咳嗽，第3咧就係唞唔到氣。咁大概嚟講咧，發燒咧大概有40%多嘅人會有發燒嘅，咳咧就有大概1半嘅人會咳嘅，而呼吸困難嘅咧就大概係10個之中有3個，即係唔係全部嘅人都有晒全部呢啲象徵嘅。
This is a typical X-ray of a patient with COVID on the right. This is actually a patient that we cared for at Zuckerberg San Francisco General. And what you see on the left is the same patient's chest X-ray a few years prior, which was basically normal. And basically with COVID, as in any pneumonia, you see areas of the lung that are white, which normally they're mostly black or gray. You can see that most of the lungs on the X-ray to the right are whited out, whereas the normal X-ray to the left, most of the lungs are black or gray.
咁大家都見到呢啲 X 光片啦，咁咧呢啲圖片咧係同一個病人嗰度攞出嚟嘅，一張咧左邊嗰張咧就係幾年之前影噶啦，呢個就係佢嘅正常嘅肺片嚟嘅，冇病嘅。咁咧右邊嗰張咧就係而家咧佢感染咗呢個 新冠肺炎啦。咁你見到咧嗰個肺部啊，你見到一條條嘅肋骨啦，後邊嗰度嗰啲個肺部嚟嘅。咁你見到佢咧就係變咗係白晒、花晒，好似啲磨砂玻璃咁樣嘅。
So while the X-ray for COVID is relatively nonspecific, and that same pattern is seen in a wide variety of pneumonias, I think one of the things that we've appreciated with COVID is that there's a very characteristic chest CT scan that when you see that, you're very highly suspicious of COVID. And this is that same patient. This is her chest CT scan. And the key features of this that really make physicians suspicious of COVID is that there's a peripheral distribution of the abnormalities. And so most of the abnormal findings are towards the outside, so closer to the chest, and rather than being located towards the middle where the heart is. And so you can see sort of many areas of gray, which we call ground glass, on both sides, but mostly towards the periphery and relatively less so towards the middle. And that's very characteristic for COVID.
好多不同嘅肺炎照出嚟嗰啲 X 光片咧，就同你正話啱啱睇完嗰張 X 光片咧差唔多嘅，所以係分唔出到底係咪呢個新冠肺炎嘅。咁但係咧，而家你睇呢張嘅電腦掃描嘅切圖咧，我哋咧就可以睇到呢個係好明顯咧係一個新冠病毒嘅感染者嚟噶啦。點解咧？係因為咧，我哋見到有啲特徵嘅，呢啲特徵咧喺其他嘅肺炎嘅病人身上面係嘅電腦掃描咧係睇唔到嘅。個特徵咧就係咁啦。你如果呢個咧係一個環切片嚟嘅，即係喺個身嗰度打橫咁切一刀咁，然後睇落去到底呢個肺係點樣嘅。咁咧嗰個特徵咧就係咧，你見到嗰個佢白色花嗰啲部分咧，佢係比較貼邊嘅，貼住嗰個肺嗰個肺膜個邊嗰度嘅。咁咧我哋會見到咧個肺膜係厚啲啦，而且佢咧嗰啲白色花嗰啲嘢咧就貼邊啦。咁呢個咁嘅情形咧，就會知道等我哋咧係非常非常之懷疑呢個人咧係有呢個新冠病毒啦。
The way the patients with COVID pneumonia present is with what we call hypoxemia. So they have low amounts of oxygen in their blood. And so the way that we treat that medically is to provide supplemental oxygen. This diagram here shows the different types of supplemental oxygen that you may receive as a patient with hypoxemia, ranging from what we call nasal cannula, which is what the woman is receiving in the upper left, all the way to mechanical ventilation, which I'm going to talk about in a second, which is what the woman in the bottom right is receiving.
呢個新冠肺炎帶俾我哋其中最麻煩嘅一個併發症嘅問題啦，就係我哋嘅血係缺氧嘅。咁血液缺氧咧，就即係器官亦都缺氧啦。咁我哋係會好麻煩啦。咁於是我哋就要幫啲病人俾啲氧氣佢啦。咁點樣俾法咧？就有幾個方法嘅。最輕微嘅方法咧，就可以俾條氣管佢擺喺個鼻嗰度，就等氧氣由個鼻嗰度入去。咁咧，如果佢需要多啲氧氣嘅時候咧，如果太多氧氣由呢條管仔嗰度出咧，佢係會個鼻嗰度係非常之唔舒服嘅。咁咧就要改用口罩啦。咁係可以用個口罩放啲氧氣俾佢嘅。咁如果呢啲管同埋口罩都唔得嘅時候咧，佢如果自己個人弱得滯，連去呼吸都呼吸唔到嘅，冇力嘅，咁我哋就要用個呼吸機去幫佢用高壓打啲氧氣入去個肺嗰度，等佢有氧氣。但係咧有啲人咧俾咗氧氣佢咧，佢根本個肺咧已經缺乏咗呢個吸收呢個氧氣嘅功能。咁於是我哋冇辦法啦，最後嘅步驟咧就係要用一個人工嘅肺去幫佢換咗啲氧氣落嗰啲血液嗰度，然後再由啲血液輸翻去佢身體嗰度。咁呢個咧就係最嚴重嘅情況。
So patients who have COVID pneumonia that progresses to ARDS often require what we call invasive mechanical ventilation. When they're on a ventilator, the typical strategy for how we ventilate them is what we call low tidal volume ventilation. This is very different than how we normally breathe spontaneously. And so it's very, very uncomfortable for patients most patients do not want to be ventilated with low tidal volumes. And so as a result of that, patients who have ARDS and are on a ventilator receiving low tidal volume ventilation require heavy sedation so that they breathe with the machine rather than against the machine. And when the sedation is insufficient and the patient is still trying to breathe on their own, we often have to paralyze them. So we give them a medication through their vein so that they actually cannot move any of their muscles and the machine can do the breathing for them. And then in very rare instances, when patients have such severe hypoxemia that we cannot adequately maintain oxygenation using a mechanical ventilator and breathing pure oxygen, the patients can go on, in essence, cardiopulmonary bypass that you may be familiar with if people are having bypass surgery. And we call it ECMO for short, which stands for extracorporeal membrane oxygenation, where we use an external device to put oxygen into the blood and take carbon dioxide out and allow the lungs to rest. This therapy is only available in a very few select medical centers, one of which is UCSF Medical Center on Parnassus.
咁正話各位都見到啦，我哋係有4個方法俾氧氣病人。頭嗰2個咧，即係用個氧氣管同埋用個氧氣嘅口罩咧，係可以喺普通嘅病房嗰度俾氧氣病人嘅。但係咧，當你要用到嗰個機械嘅呼吸機或者用到個人工肺嘅時候咧，咁我哋咧就一定要將個病人擺喺呢個深切治療部先至可以俾佢啦。所以深切治療部嘅病人咧，通常咧就係一啲非常之嚴重嘅例子嘅病例咯。咁佢哋喺嗰個深切治療部嗰度咧，因為用呢啲咁嘅機咧，好多時咧我哋都係要用藥去麻醉佢，去昏迷佢，等呢啲咁嘅機咧係可以同佢去運作嘅。用呢個機械嘅呼吸機嘅時候咧，好多時啲病人如果你唔將佢昏迷嘅時候咧，佢因為太過辛苦嗰條管喺個喉插入去咧，佢有時用隻手去掹嘅嗰條管啦，咁係非常之危險啦。有時咧佢咧就同呢個機咧，如果佢係醒咗嘅話咧，佢就同個機喺度，佢又去呼吸，個機又去呼吸，咁咧就搞到好亂龍咁啊！大家好似打交咁樣。咁所以咧，為咗可以控制到佢呢個氧氣嘅情形咧，我哋咧係要將佢昏迷咗，咁然後我哋可以將個機校嗰個量，咁然後俾一啲適當份量嘅氧氣俾佢嚟到幫助佢嘅。咁咧呢個咧就係用個呼吸機啦。咁至於個心肺機咧，心肺機咧就唔係個個醫院都有嘅喎，其實係好少醫院有嘅喎。主要有呢啲機嘅醫院咧，就係可以做開心臟手術嗰啲咁嘅醫院就有啦。咁呢個心肺機就係當我哋俾氧氣病人，點樣俾佢都好啦 ，OK？ 用個機器俾又好，用個管又好，用個口罩又好。當佢個肺冇能力去做呢個交換氣體嘅工作嘅時候咧，咁我哋就算俾啲氧氣佢都冇用。咁如果係咁咧，就要用個人工肺啦。到個人工肺嘅時候咧，就嗰啲血咧就出咗嚟。咁呢個人工肺咧就喺出邊嗰度，即係體外啊，同佢將啲二氧化碳抽走咗，然後加翻啲適量嘅氧氣入去，就再將啲血運翻入佢身體嗰度，再帶去其他嘅各個器官，等佢嗰啲器官咧就唔會缺氧。咁就係呢個人工肺嘅問題。我哋咧就喺 UCSF 醫院喺 Panassus 嗰度咧，就係有個人工肺嘅設備嘅。至於三藩市總醫院咧都冇嘅，所以三藩市都有幾間醫院有嘅，咁但係其中一間咧就係我哋 UCSF 嘅 Panassus 嗰度嘅醫院。咁啊，希望病人就真係唔好要用到呢個人工肺嘅程度咯，因為如果用到個程度咧，係真係好難救得翻。
These 2 slides will talk about really things that we've learned that are, I don't want to say unique to COVID, but that are really special to COVID. So the first is that we realized early on that many COVID patients do better when they're lying on their stomach in what we call the prone position than they do when they lie on their back in the supine position. We've actually taken at Zuckerberg San Francisco General for patients who are not in the ICU or patients who are in the ICU but are not on mechanical ventilation to asking them to do what we call self-proning. And so that's the diagram on the left, where we ask them to spend time on their stomach, and then to turn to one side, to raise the bed up, to turn to the other side, and then to go back on their stomach. For patients who are in the ICU and on a ventilator and are sedated and often paralyzed, they obviously can't do this on their own. And so we have two possible ways of doing this. We have what we call a proning team. So a group of nurses and respiratory therapists and technicians who flip the patient by rolling them on the bed sheet. And then the diagram to the right is a machine that prones the patient as well. This is a rotoprone bed, and so the patient is strapped into the bed, and the bed gently rotates from side to side and then can be turned into the prone position manually.
呢張圖咧就係講我哋瞓覺嘅位置。咁原來瞓覺嘅位置咧係可以影響我哋嘅呼吸嘅喎。咁對於有呢個新冠肺炎嘅病人嘅情況嚟講咧，呢個可能係一個關鍵嘅環節嚟嘅。咁點解咧？因為咧，我哋個肺啊，其實喺個心後邊嘅，即係個前邊嘅胸骨咧，後邊嗰個咧就係個心臟，再後邊嗰個先至係肺嚟嘅。咁所以當我哋仰臥嘅時候啊，即係個面向天嘅時候咧，個心咧就喺上邊啦，咁個肺咧就喺下邊啦喎。咁嗰啲水咧，如果即係嗰啲有新冠肺炎嘅病人，佢個肺裏邊可能有啲血水噶嘛，咁咧嗰啲血水咧就喺下邊個肺嗰度咧就打橫咁樣浸咗成個肺。咁呢個咧就係可能出現嘅一個情形。咁但係當我哋將個病人趴喺度瞓嘅時候咧，變咗咧個心咧就向咗去下邊嗰度啦。咁肺咧喺個黐住個背脊嗰度咧，背脊就向上啦。咁個肺咧咪即係浮咗喺上面嗰度，咁嗰啲氧氣啊，咁咪比較容易去個肺裏邊去做呢個呼吸嘅工作咯。咁所以咧，而家喺個醫院嗰度嗰啲病人咧，好多時咧我哋係同佢轉身嘅。咁咧轉咧就係由俯臥，即係個面向下邊啦，俯臥啦，就轉去隔咗一段時間咧，就同佢轉去右邊身，然後跟住咧就同佢坐下起身。等嗰啲血水咧就流咗去下邊嗰度，咁然後咧就跟住又轉另外一邊身，咁然後跟住咧又轉翻去個面向下咁樣瞓嘅。咁你見到呢4個瞓嘅姿態咧，都唔係話平時我哋咁樣瞓係仰臥啊，即係個面向上咁樣瞓嘅。OK， 咁於是我哋咁樣做法咧，就係因為有研究做咗出嚟咧，就係有啲研究啊，認為咧咁樣嘅方法瞓咧係會幫助嗰個病人嘅氧氣嘅吸收。咁而家醫院裏邊咧係有一啲醫療小組啊，有一啲小組嘅人裏邊啊，有個護士啦，有個嗰個呼吸嘅治療師啦，咁然後咧就有啲人幫手，即係嗰啲助手啦，去幫個病人去轉身嘅。佢哋同一個病人轉完身咧，又換咗嗰啲咁嘅保護衣咧，然後咧又去另外間房又幫第二個病人轉身咁嘅。每次轉身咧都可能要搞10零分鐘嘅。咁亦都有一個方法咧，就係有一啲特別嘅床啊。咁有一啲病房咧，有一啲特別嘅床咧，嗰啲床咧係可以幫個病人轉身咯。咁呢啲床咧就相當貴下啦，就唔係周圍都有啦，亦都唔係個個病房都有啦。
The last slide I'll share before we transition to Q&A are some of the ICU modifications that we've made due to COVID. The first, as I'm sure you're all aware, is that for all COVID patients, we wear PPE. And for us, that includes the N95 mask that you're all familiar with, either goggles or a full face shield, impermeable gown, and then actually 2 pairs of gloves. Another modification we've made, which is uniquely COVID related, is to minimize people coming in and out of the patient's room. In many cases, we externalize both the IV medications as well as the ventilator, so that the doctors, nurses, and respiratory therapists do not actually have to go into the room in order to give medicines or adjust the ventilator. And then the final modification is, even though I've been faculty for 25 years in the ICU at Zuckerberg San Francisco General, it wasn't until COVID that I actually put on a air purifying respirator. We call it a PAPR. as you can see me in the papper on that picture to the right, and then the diagram or picture of a papper on the lower right.
呢個咧就係三藩市總醫院嘅深切治療部裏邊一啲砌圖嚟嘅。咁大家見到咧喺右下角嗰度咧嗰條冷巷咧就係喺個深切治療部嗰度嗰條冷巷裏上面咧，你見到係好多嗰啲儀器咧就堆晒喺個病房門口嗰度，個病房度門就閂咗啦，但係前面咧就好多嘅儀器啊、電腦啊、IV 管啊、呼吸機啊嗰啲嘢，通通堆晒喺個冷巷嗰度嘅。咁主要嚟講咧就係將我哋要同病人做嘅嘢咧，就盡量喺個房以外嘅地方可以做咗佢，就減低入房嘅機會。但係因為每一次入房咧，你哋睇到咧，佢哋係全身裝甲咁樣入去，好似上戰場咁嘅。咁佢哋就戴呢啲咁嘅口罩、面罩、手套、衫啊咁樣戴嘅時候咧，有一個順序嘅過程啦。當然係，亦都係咧非常之嘥時間，亦都係非常之昂貴，亦都係咧呢啲咁嘅衫啊、口套啊、帽啊嗰啲咁嘅嘢咧，有時候咧。好多時候咧，我哋係唔夠用嘅。我哋應該係有最少有1-2個月嘅預備嘅貨物喺度嘅，但係咧好多時都係冇嘅，即係可能得1-2個禮拜剩低咁樣係，即係嗰啲資源啊係非常之緊咯。有時係真係好驚住係唔夠用嘅。咁所以咧，呢個就係咁啦。如果當個病情爆發嘅時候咧，多人病嘅時候咧，多咗人要用呢個深切治療部嘅服務嘅時候咧，我哋真係好多時係一下咧就整個措手不及咧，又可能唔夠床位啦，又可能唔夠儀器啦，又可能唔夠呢啲咁嘅衫啊、保護衣啦，或者口罩啦，或者係手套啦咁，即係好多嘢咧都可能唔夠嘅。所以咧，醫院嘅設備咧，如果係足夠嘅咧，咁個病人喺出邊爆發咧，我哋係有能力去吸收多啲病人。如果冇能力嘅時候咧，咁咧就會好多人咧係我哋救唔得返，因為佢哋係冇機會入嚟呢個深切治療部嗰度得到應有嘅服務嘅。所以大家咧都係即係唔好掉以輕心，就真係盡量去做一啲防衞嘅工作。希望你哋唔需要入嚟呢個深切治療部嗰度，即係受呢啲咁嘅治療咯。亦都係一個非常之受苦嘅過程嚟嘅。個病人喺個房裏邊係非常之受苦嘅。咁員工喺出邊咧就喺出邊嗰度預備打仗咁樣。咁所以大家咧都唔係一個好嘅經驗嚟嘅。咁黃醫生咧就話佢做咗20幾年醫生咧，從來都未見過呢個咁嘅頭，未戴過呢個咁嘅頭盔。因為頭盔好似啲太空人嗰啲頭盔咁樣，黑色嗰條管咧係放嗰啲淨化咗嘅氧氣入去俾佢呼吸嘅，咁就包到個頭密一密啦。咁然後當然用完之後出到嚟咧，就成套嘢要去消毒啊咁樣。咁醫院嗰度咧都唔係好多套呢啲咁嘅嘢嘅，咁就所以有時個設備如果唔足夠嘅咧，咁就會影響個醫療嘅效果咯。希望大家睇咗呢啲咁嘅情況之後咧，心裏邊有個警惕，就可以即係同政府啊咁樣佢哋嘅推薦咧係合作啲，就出街嚟戴口罩啊，大家做隔離啊，盡量唔好感染到。呢個就係預防就係最好嘅方法嚟嘅。
Let's take a look at the questions. These are the questions that came in beforehand, and we also have quite a few that are here, and we'll try to answer them as much as possible, but we may not be able to answer them all. What is the worst thing for patients in the ICU from your perspective?
So, of course, there's several ways to answer this question. I'll try to be brief. Obviously, the worst thing is that they're critically ill, and they're at very high risk of passing away. I think something that may be uniquely COVID-related that I think is getting at this question is that because of COVID and because of the policies that have been put in place to minimize the spread of COVID to other individuals, patients with COVID cannot have any visitors for the most part. And so you can imagine being in a life-threatening situation and your family cannot visit with you. And that's terrible, both for the patient, but especially for the family.
喺病人住喺呢個深切治療部嗰度，最慘係咩嘢咧？咁黃醫生咧就答：最慘咧就莫過於死啦，因為喺深切治療部嘅病人咧係好多都過唔到關嘅。但係佢話第二慘咧就係病人同家人之間咧係大家互相擔心大家，因為個病人喺裏邊個房裏邊又病得好重啦，佢又見唔到自己嘅家人啦， OK， 家人喺出邊咧又擔心入邊嘅病人，但係佢又入唔到去探佢，咁呢個係一個相當凄慘嘅情形嚟嘅。
So, Dr. Huang, none of the family members can go in. Let's say that the patients, we know that the patient's dying. And so do we make exceptions in those cases?
Yes. So I didn't want to get into some of the details, but yes, that is absolutely the case. So patients who are in the process of actively dying, we do allow family in, but it's regulated as well. So if you have a large family of 20 or 30 members, for obvious reasons, you cannot all go into the room at the same time. We only allow a few members at a time and a few members per day.
即係我哋都會俾一部分嘅親人入去，但係就唔可以一齊入去。
So the second question is, do a lot of patients develop delirium because of the isolation and quarantine? 第二條問題咧就係話嗰啲病人咧會唔會產生幻覺或者係神志不清啊？因為自己一個人咁孤獨咁樣喺個病房嗰度韞住。
When patients recover, we see a lot of delirium in COVID patients, maybe more so than in other patients who are in the ICU. And I think there are several possible explanations for that. One may relate to COVID itself in the brain, causing COVID direct effects that result in neuropsychiatric symptoms. Another reason is that these patients are on very high doses of sedative medications for very long time periods. One of the other unique things about COVID or special things about COVID is that when these patients come to the ICU, they stay in the ICU for an extremely long period of time. I think in general, much longer than other patients with other pneumonias that also develop ARDS. And so the longer you're in the ICU, where people are bothering you 24 hours a day, and there's not a normal day-night cycle where you're up during the day and you're asleep during night, all those things promote delirium.
阿黃醫生咧話咧，佢喺治療呢啲新冠肺炎嘅病人之中咧，係見好多嘅，咁係好多病人咧都搞到神志不清啊，好混淆啊咁樣嘅。佢主要原因咧就有3個。第一咧就可能係個病毒自己上咗腦啊，咁咧就搞亂咗嗰啲神智。第二樣嘢咧就可能我哋俾病人用嘅藥，因為我哋好多時佢要用嗰個呼吸機咧，我哋就要用啲鎮靜劑俾佢啦，等佢去瞓覺安靜啲，就唔好同個呼吸機打交。咁用呢啲藥用耐咗嘅時候咧，啲藥有副作用咧，就可能影響佢嘅神志。第3樣嘢咧就同住喺呢個深切治療部有關嘅。佢話大部分呢啲新冠肺炎嘅病人咧，係比其他肺炎嘅病人咧住喺深切治療部咧係住耐好多嘅，可能要住幾個禮拜嘅。咁所以咧佢哋成日喺個深切治療部嗰度咧就日夜不分啦。咁呢個咁嘅顛倒日夜嘅過程咧，就會影響到佢神志嘅清醒嘅狀況嘅。所以黃醫生咧就話佢見到呢個神志不清嘅情況咧，喺呢啲新冠肺炎嘅病人之間咧係非常之多嘅。
After patients left the hospital and go home, would they have antibodies for the COVID in the future? And if so, how long will it last?
I wish Dr. Chin Hong was still here because he's the infectious disease specialist. I'm the lung specialist. But yes, patients definitely should have antibodies and should be immune for COVID. But I think the question of how long-lasting the immunity is has not been answered. One thing that I could just mention right now is that one of the therapies that we're using for patients with COVID is what we call convalescent plasma. And so what that basically is that patients who've recovered from COVID and presumably have antibodies have graciously donated their blood to the hospital, and we take their blood and we give it to a patient with acute COVID. The idea being that the patient who recovered has antibodies and that we can then use those antibodies from another patient to fight the COVID infection in our patient. So it's called convalescent plasma.
第3條問題咧就係話嗰啲受過感染嘅病人， 翻咗屋企嘅時候，咁佢哋身體有冇呢個抗體呢？如果有呢個抗體，又會唔會幫到佢哋唔再受感染呢？如果係唔再受感染，又可以維持幾耐呢？咁啊，黃醫生嘅答案咧就係話，佢哋病人離開醫院嘅時候咧係有抗體嘅。咁呢啲抗體咧應該咧係會幫到佢哋唔再受感染一段時間。咁但係最近英國嗰度咧就有份報告出咗嚟咧，就係話經過3個月之後咧，呢啲抗體嘅數目咧係大大咁樣減低咗嘅。咁啊減低到咩情形之下就唔會再幫到佢哋咧？呢個亦都唔係幾清楚。但係我哋喺治療病人之中咧，就係有用一個方法。就係用一啲曾經受過感染嘅病人嘅血清去幫呢啲受咗感染嘅病人，就希望呢啲受過感染嘅人嘅抗體咧，可以幫到而家受緊感染嘅病人。
So this question is, since a lot of patients have pneumonia-like symptoms and that there's a lot of fluid in the lungs, so if we give them less fluid, would that help them? Is that one of the treatments?
So that's a great question. We do try to what we call run the patient dry. So we try to minimize the intravenous fluids to the least amount possible. And we can give them medications, diuretics to help them pee out the fluid. But the problem is that patients with pneumonia, they have lung damage and the integrity of what we call the alveolar capillary membrane, so the thin membrane that separates the air sac from the capillary blood vessels, is damaged. And so when the blood goes through the lungs, some of it is going to leak out. Obviously less if there's less blood volume, but some of it will still leak out.
第4條嘅問題咧就係話，嗰啲病人好多時個肺裏邊咧有水分，有積水嘅。咁如果係有積水嘅時候，會唔會我哋俾少啲水分佢哋，就等佢哋少啲積水咧？咁啊，黃醫生嘅答案咧就係話係嘅。其實咧，呢啲有肺炎嘅病人咧，好多時咧肺裏邊嗰啲氣泡啊，係佢個表層咧係爛咗，係即係受咗傷害嘅，咁咧就變咗嗰啲血咧喺個肺部嗰度咧係會流出嚟嘅，因為佢嗰啲微絲血管咧係傷咗啊嘛，咁啲血咧就會滲出嚟。咁佢話咧如果係嗰個病人身體裏邊係少啲水分嘅話咧，咁咧就滲出嚟嘅血咧就可能係少啲，咁咧間接嚟講咧都可能有對病人有少少嘅幫助，所以佢哋都唔會俾太多水分俾呢啲受咗感染嘅新冠肺炎嘅病人。
Question: If we get the flu on top of the COVID infection, will we get sicker?
That's another great question. We're going to find out in a few months.
Pneumonia or the flu on top of the COVID infection.
Yeah, it's a great question. We're going to find out in a few months as the COVID pandemic collides with the annual seasonal flu. It's definitely going to make it much more challenging for clinicians because right now at this time of year, pretty much anybody who's coming in with fever, cough, shortness of breath, flu-like symptoms, we're assuming it's COVID because it's not flu season and we're treating them appropriately. Come the winter, when it's flu season, a lot of patients coming with those symptoms are going to have the flu, but others are going to have COVID, and some are going to have both COVID and the flu. So it's going to be trickier for clinicians to sort that out.
第5條問題咧就係話，如果我哋有感冒，再加上有埋呢個新冠肺炎，咁樣會唔會個病情更加嚴重咧？咁阿黃醫生咧就話，當然我哋而家未到冬天啦，咁啊應該係未有感冒嚟嘅。但係如果到冬天嘅時候，一個病人有一啲咁嘅感冒嘅症狀咧，咁我哋其實咧唔知道佢係淨係有感冒啊，抑或係有新冠肺炎咧，抑或係兩樣都有咧。咁啊，到時要到冬天嘅時候，我哋先知道，如果佢兩樣都有嘅話，佢嘅病情係咪會比淨係單一有呢個新冠肺炎係更加嚴重啦
？Online Q&A?
Go ahead and answer the questions.
Okay, so I'll start with the earliest questions that I received, and then I'll just work my way down. Apologies in advance. I'm a pulmonary ICU specialist, so I try to stay in my lane and talk about things that I know well and not talk about things that I know a little less well. So the first question is, why is President Trump telling the country that everything is under control? Seems like his data are different than the reality. Where did he get his data from? I could go on for a long time about this question, my answer, but I think probably similar to many things in the world, perception can be different in different people's minds. And so presented with the same information, some people will say the glass is half full. Some will say the glass is half empty. I think his perception on what's going on in the country is glass half full. And there's an obvious personal gain for him saying that it's glass half full. And I think in the interest of being polite, I'll leave it at that. So the next question is, San Francisco is not on Governor Newsom's county watch list. Are we doing as much testing in San Francisco compared to LA or Orange County? There's relatively less shortage of testing in San Francisco compared to earlier in the epidemic. I don't know how it compares to LA or Orange County. As people from the Bay Area know, we were one of the 6 counties to shelter in place. And so we did a particularly good job, I think, with sheltering in place. And maybe I'm going to say this a little bit with my tongue in my cheek. We don't have nearly as nice beaches as they do in LA and Orange County. And so as Peter said earlier in the session, that was one of the reasons probably why things got out of control in many parts of the country, is because people got tired of sheltering in place. They got fatigued and they lost some of their personal discipline, and they went to bars, they went to restaurants, they went to beaches and large gatherings. So whether that's the particular case or there's something else going on, I'm not sure I'm the expert to talk about, other than the comment is correct that we're not on the county watch list. Relatively speaking, we're doing much better than LA or Southern California. The same individual asked about what's the actual difference between an N95 and a KN95, if any. I'm definitely not an expert on this topic. The N95 is a medical respirator that's designed for medical use and is supposed to filter out 95% of particulate matter. My general understanding is that KN95 is mostly in other countries like China. And I don't know if it has the same exact properties as the N95.
It's the same.
Should we wear face shields? Does it offer additional immunity from transmission? That's kind of a risk assessment and a personal assessment. One of the mucous membranes, as you know, are the eyes. And so it's possible that you could get COVID if somebody were to cough or sneeze and some of the respiratory droplets were to contact your mucous membranes of your eyes. And so obviously in that case, wearing goggles or even glasses or a full face shield would protect you against that. And then I guess there's also the barrier if you're wearing a shield, helping out if you're wearing a regular cloth face mask or a surgical face mask, in terms of providing an extra level of protection. But I think we're having, as a country, a difficult enough time getting people to wear regular cloth face masks, never mind surgical face masks, never mind N95 masks. I'm not sure how asking individuals to wear face shields is going to work, but on an individual level, it does provide probably some extra benefit. I don't have any great recommendations for what kinds of masks to use other than, I think, simple cloth masks that you can purchase for $10 or $15 are certainly fine. Some people just use their own bandana or something and put it around their face. The general idea is that, as Peter said earlier, you may have COVID, and by you putting a barrier right in front of your face, that offers some protection to the people you come in contact with against respiratory droplets. And then secondarily, it may provide you a slight barrier against somebody else who has COVID, coughing or sneezing on you and blocking those respiratory droplets from hitting your mucous membranes. So any barrier that you have is better than no barrier. I'm pretty sure you cannot buy N95 masks on Amazon anymore because they're restricting the sale for healthcare facilities because sadly enough, there are not enough N95 masks for all the healthcare workers who need them and all the first responders. So if you happen to have one, you can certainly wear it. You can certainly reuse it multiple times, but probably not indefinitely.
Thank you so much, Dr. Huang, for answering the questions. 多謝黃醫生正話答嗰啲問題㗎。My internet connection was not too stable for a little while, and so I was breaking out. And Dr. Huang was kind enough to just take over and answer other questions that came in today. So we thank him a lot. 正話咧，因為我嗰個網路咧唔係幾穩定，咁所以咧嗰啲聲咧就唔清楚嘅。咁黃醫生咧就好好人，就自己去答晒嗰啲問題佢。咁我哋真係好多謝黃醫生。We want to thank you for joining this town hall and staying late with us. 我哋多謝大家今日同我哋參加呢個城市論壇。We are living in extraordinary times indeed. COVID-19 can get some people very, very sick or not at all. Regardless, we do not want to get sick and go into the intensive care, especially after what we have learned from Dr. Huang tonight. All of us are gatekeepers in this pandemic, so we urge you to maintain vigilance in 3 things. Keep the 6 feet distance between people, wear masks to cover your nose and mouth, and wash hands often with soap. In protecting ourselves, we also protect each other. Together, we can greatly reduce the transmission of this virus and reduce the number of patients needing intensive care in hospitals. Once again, we want to remind everyone that the beginning symptoms of COVID-19 can be vague, atypical, or confusing. If you do not feel well, please don't hesitate, but call your doctor for medical advice and treatment. 我哋嘅生活咧係的確非常之艱難嘅。呢個新冠肺炎喺某一啲人身上面咧根本係冇症狀，但喺某一啲人身上面咧就佢會令到佢哋病得非常非常嘅重嘅。無論點啦，尤其是喺我哋聽咗黃醫生講患者喺呢個深切治療部受苦嘅經歷之後咧，我哋就真係唔想去冒險咯。所有嘅人咧都應該一齊守住呢個關，去避免啲新冠肺炎喺呢個社區嗰度繼續傳播，所以我哋一齊要繼續齊心抗疫。大家做3件事，第一就係保持呢個人同人之間嘅距離要有6尺以上。第二呢，就係戴口罩冚住我哋嘅口同鼻，同埋呢就要經常用番梘洗手。我哋喺保護自己嘅同時其實亦都係互相保護嘅。咁樣我哋就可以減少呢個病人嘅傳播，同埋避免醫院嘅深切治療部咧有人滿之患。咁我哋想再次提醒大家咧，就係一啲開始時嘅症狀咧，可能係非常之模糊或者係非典型嘅。咁如果你哋覺得身體有咩唔舒服咧，就唔好猶豫啦，就請你打電話俾醫生，盡早得到佢哋嘅關照同埋治療。Our website address is hi.ucsf.edu. Please visit the website for the previous recorded town halls or interviews of our physicians and myself by the Chinese and mainstream media. With help of our finance director, Anthony Chan, we also have a COVID-19 case tracking map, so you can click and see the cases and trends. 我哋嘅網站呢就係 hi.ucsf.edu， 你係可以喺嗰度睇返到以前錄製咗嘅論壇啦，或者呢係睇到其他中文傳媒或者係主流傳媒對我哋嘅醫生同埋我本人嘅採訪嘅。咁喺呢個我哋財政主任 Anthony Chan 嘅幫忙之下呢，我哋仲提供咗一個新冠病毒病例嘅跟蹤圖。咁你可以點擊嗰度呢，就睇到嗰啲病例同埋死亡嘅總數同埋趨勢㗎啦。We want to thank our panelists and everyone on our production team, Raymond, Dan, John, Joyce Chan and Anthony Chan. 咁我哋咧好多謝我哋全個嘅 UCSF 嘅團隊去幫我哋製作呢個今日嘅城市論壇嘅。Stay well and stay safe， 祝你哋健康。Goodbye for now and see you in our next town hall. Thank you。咁我哋而家暫時同各位講拜拜，下次再見。